Bonjour, everyone. My name is Dr. Krista Kosterman. I am the Chief Science Officer here at the DNA Company, and I have the absolute privilege and pleasure of being with you this evening. This evening, we have a special treat as well. I get to introduce a new clinician to the DNA Company, a new member and participant of our panel this evening. And for those of you who have a history with the DNA Company, a returning face. Allow me the privilege and pleasure of introducing Dr. Adelia Sapp. She is a naturopathic doctor and someone very topical to tonight, has a lot of additional training and expertise in the space of dementia and Alzheimer's. So we don't need to hear me ramble about her. Dr. Sapp, I wonder if you could give us a moment just to introduce yourselves to our audience, especially speak a little bit to your history with the DNA Company and then your training in Alzheimer's and dementia.
Hi, Dr. Kosterman and Dr. Varden. It's a pleasure to be here. I'm a former employee of the DNA Company. So I was working for you guys when you were just a tiny little startup in Mississauga, making supplements by hand in the back, working with Dr. Mansour, who I got a lot of good training with. I ended up I'm a naturopathic doctor trained in Toronto, Canada. I ended up moving to the States a couple of years ago to work for a health institute that had a focus on cognitive health. So worked with a lot of burnt out executives, many of whom had some mild form of cognitive decline. So cognitive decline, is a spectrum, and Alzheimer's is a form of dementia, which is an umbrella term. So there's a lot in there. There's ADHD, there's autism spectrum, there's symptoms of dementia, and those all fall in the realm of cognitive health. So in my practice, I focus a lot on cognitive health as well as mental health. And I love studying genetics ongoing and their relationship to mental and cognitive health and Alzheimer's in this case.
Yeah, well, we're so very grateful to have you and your practice and your curiosity back with us, in particular this evening, where we want to dive in with yourself, Dr. Varda, and myself into the very murky, confusing, fearful topic even of Alzheimer's and separately of dementia. I want to make sure, at the beginning of these, we like to really gauge where the audience is. We like to gauge who is coming to us and why they're coming to us. So powers that be, gods that be, if you could pop up the results to our survey, perhaps we just open things up a little bit by understanding where our audience is coming from so that throughout this session, we can always make sure we're talking to you and in support of you. So when we ask the question, do you have people that you care about with Alzheimer's or dementia? It was about a 50-50 split. So about 50% of the audience tonight here has people in their life who are impacted by dementia or Alzheimer's. And then the other half is just looking for information. And I would imagine to the end, I'll suppose for the audience's behalf, to the end of prevention. I think it's not anything that anyone cares to endure. So to the end of prevention. We next asked people, what sort of knowledge set do you come to us with? And this will really help us in some of the descriptions, and especially Dr. Varden's going to offer a research update in just a moment, but majority of our audience, about 70%, feel like they know little bits, probably a little bit that pop science and maybe Instagram or Facebook or TikTok is offering them, but there's a lot more to learn. So we'll make sure that we honor where you're at. And lastly, and I think this is such a fun question, and I'm so grateful we asked it. We asked the question, do you know the difference between Alzheimer's and dementia in terms of symptomology, right? And so 70% of our audience here said nope. And so I hope by the end of this webinar that you'll be able to very confidently and very assuredly be able to say, yep, I have a grasp on that. And for the 32%, top notch. Toss some of those answers in the chat. I'm curious what your working difference between the two is. Yeah, we'd love to hear from you guys. Yeah, so I wonder, Dr. Varden, this in preparation for this, you brought forward a very interesting and recent publication from Nature in regards to a GWAS study. So a study that effectively looks at a whole bunch of different genes and understands from there. I wonder if you want to offer our audience a little bit of an update as to what this paper looked at and at a high level what some of those findings were.
Absolutely. So actually, this publication just was published yesterday in Nature Scientific Reports, and it was called Microvascular and Cellular Dysfunctions in Alzheimer's Disease, an Integrative Analysis Perspective. And I know that can be a lot of words there, but really, what the study was looking at is it was trying to understand what might be the cause of Alzheimer's disease. And of course, all of you know, and why you're here, this is a condition that leads to memory loss and thinking problems. So the scientists really focused on how tiny blood vessels in the brain and the cells around them, as well as the material that supports the brain cells called the extracellular matrix, might be involved. And what they found is that the blood-brain barrier, which acts like that protective shield that prevents harmful substances from getting in the brain, it found that damage to that barrier might happen early in Alzheimer's disease. And, of course, the cells and the extracellular matrix area, excuse me, can be harmed due to substances that can enter and pass through that blood-brain barrier, worsening the disease. And they also found like the extracellular matrix. This is that network that provides structure and support for the brain cells. And in Alzheimer's, there are changes and damage to that material that can affect how the brain cells communicate and function. Also, the cells, specifically oligodendrocytes, these are special cells in the brain that help protect nerve fibers by forming a coating around them like insulation on electrical wires. And the study found that these cells don't work properly in Alzheimer's, and that can cause damage to the brain's wiring, affecting memory and thinking. And there's other pathways that they were looking at. A particular pathway that is an insulin signaling pathway can be important. And, when there are issues with this insulin signaling pathway, which I'm sure some of you have heard us talk about before, that Alzheimer's is actually now tend to be known as type 3 diabetes.
Affectionate nickname.
Yeah. So, when we talk about sugar, blood sugar regulation, insulin regulation, mitochondrial health, the life of the body, the energy, the milieu, the terrain of our bodies, our brains, these are all very important. And they focused on the part of the brain called the hippocampus. And this is very important for memory. And it definitely seems to be more affected by Alzheimer's than other areas of the brain. So it was really interesting that looking at these different aspects, things that we look at, that it's not usually just one thing, that it is affected by many different things. And when we have an idea about what the cause or what worsens the problem, then we have ideas on how can we prevent that, how can we kind of backpedal and maybe even fix it some, but definitely what we can do. Overall, that study suggested that problems with blood vessels, supporting materials, and definitely the brain cells all can play an important role, in Alzheimer's disease. So very interesting. And like I said, this is new research, just came out yesterday.
Thank you for that.
Awesome. Thank you, Dr.
Yeah.
Martin. Yeah, super cutting edge, as you said.
Yeah. And so, Dr. Sapp, I wonder, with this awareness, with some of your very specific training, how are you, approaching your working definition of what these conditions are, kind of the general term of dementia, more specifically Alzheimer's, and to an extent how they're being caused? Because if what I heard from Dr. Varden correctly was effectively there's a whole bunch of little things that will lead to this.
Yeah, yeah. So yeah, dementia is an umbrella term, and Alzheimer's is the most common form of dementia. But typically it is a progression, and it is a spectrum. So before people have, full-blown Alzheimer's, it's usually decades in the making. So it's definitely something that people can work preventively. And if there's anything I want people to take away from this podcast, it's that the vast majority is not genetic. However, genetic testing will really help you to target certain weaker factors that you might have. So I'm sure you, Krista, would probably agree that this whole concept of good genes, it's not really a thing. Because everybody has weaker areas. And given that dementia and Alzheimer's are so multifactorial, we kind of want to know what those areas are ahead of time, and arm ourselves ahead of time to work preventively. So it's really only a minority of cases that are strictly genetic. In most cases, we have genetic factors that are better to know about in advance. And we can work preventively. So, yeah.
And when you consider that Alzheimer's, dementia, these are diseases decades in the making.
Yeah.
So it's never too early to start with prevention.
Agreed. Yeah. Yeah.
Yeah. Yeah. And what would you capture in your prevention? Where would you spend your focus? So I want to acknowledge, I can already predict the answer from you both is, well, get your DNA done and figure out what your weak points are, and we should go on from there. So I wonder if we could maybe do a quick review of, common weak points, and maybe we can even touch on some of the genes associated with those common weak points. So especially a lot of our audience, I don't think we asked the question, a lot of our audience though tends to walk into this with their 360 in hand. And so I wonder if we can speak to some of the sections that can be weak and then some of the genes associated with that.
Absolutely. Yeah. So the gene that's most known is ApoE. So that's the one where people are super scared and they say, oh, do I have the Alzheimer's gene? And there's a number of different variations of ApoE. If you have one copy of ApoE4, it increases your risk of Alzheimer's significantly if you don't modify all the factors, which are diet, reducing stress, improving sleep, and we can get more into them after. And then if you have two copies, it increases your risk even more significantly if you don't work preventively. And this being said, there are parts of the globe and studies on remote areas where people have even ApoE44, which is considered the most high risk one, where people are reported to not have any cases of Alzheimer's. So that just speaks to how much the environment plays a part. But if you have those genes, you know how much more aggressively you want to pursue prevention. So let's say you got a really good report when it comes to Alzheimer's. Like let's say your TCF7L2 is optimal, your ApoE is optimal, your BDNF is optimal, your detox genes are optimal. You might, not pursue prevention as aggressively, particularly if you have no signs. But if you have an ApoE44 and you find that out when you're in your 40s or 50s, you've got plenty of time to work preventively and completely change your outcome. So I don't know if I answered your question, but
I think it's a great start. And before I toss it to Dr. Varden, maybe to explain some of those genes for the people in the back, I want to just reiterate what she said, because I think this is one of the most important points she made. Even if you have ApoE4, that is not fatalistic, that is not deterministic of you having Alzheimer's. There are people in this world that carry that variant, even the 4/4 variant. They have been studied and they do not have Alzheimer's dementia. It is not fatalistic. and what Dr. Sapp has talked about in regards to, blood sugar management, what Dr. Laura is talking about, the decades of in the making, this is kind of where we need to be focusing, especially should you have that very terrifying for many people ApoE4.
Yeah. And I think it's good for people to know that there isn't just one, there isn't a Alzheimer's gene, like you said, that's fatalistic. There's a very small minority of cases, and I don't know the exact percentage, but well under 5%, let's say, that are early onset, that are strictly genetic. But for the vast majority, that's not a concern. So,
and early onset, what I believe that is before 60.
Yeah, it's actually between 30 and 60. So it could be a really big range.
Okay.
And yeah, it would be more like you'd have to go see a clinical geneticist and get a referral. And yeah. It's not common.
Got it. Okay. So Dr. Varden, I wonder if you want to dig a little bit. So, you kind of introduced dementia as type 3 diabetes. And Dr. Adelia or Dr. Sapp also kind of mentioned a few genes that are associated with that. I wonder if you want to dig in a little bit deeper there.
Sure. Well, I mean, when you're talking about blood sugar regulation, okay, there's a lot of factors at play. So, a couple that Dr. Sapp already mentioned is the TCF7L2 gene. This really works into your insulin response. And that you'll find if you have your DNA 360 reports, you'll find in your diet and nutrition report. That's one of the main places you can find that. I mean, we do have it sprinkled throughout, but another one would be dealing with how you break down starches, and how that's going to affect blood sugar, because obviously carbohydrates, which starches are part of, don't forget, carbohydrates also include fruits and vegetables, okay? But specifically starches is the AMY1 gene, AMY1. And again, you'll find this in your diet and nutrition report, because this really speaks into starch metabolism and, how well do you break that down? Also your ApoA2, so that you've got your ApoE, okay, which Dr. Sapp spoke into, but then ApoA2, which can oftentimes be associated with fat gain to fat consumption. But you start looking at all of these as players on a team, they all play a part. They play a part in how you metabolize the fat, how you metabolize these carbohydrates, how does your insulin respond to this, and work to get the glucose into the cells, which works into another gene that you'll find in your diet nutrition report, and that is your SLC30A8, the number 8. And this works for zinc transport in relation to what happens in the pancreas with creation of insulin. And how well is that working for you? Is this something where, you don't do that very well and you may need to supplement with zinc? But again, we are looking at more players on the team that start to build the larger picture of any susceptibility that you need to be aware of to address for prevention of being in that percentage that could possibly get Alzheimer's. But again, I want to reiterate, and I know we've already said this a few times, just because you may have a particular variant of any one of those genes, it does not mean that you will get Alzheimer's or that you will get dementia. This is why you are getting and the knowledge, why you are getting your DNA 360 reports done. So that way, your blueprint, you have your map, what you should be doing to be in that percentage that doesn't get the disease.
Yeah. Which is, I love that point brung home again. It's so important, and it's something I think we'll have to keep echoing. Yeah.
Yeah,
Oh, please, I don't want to interrupt.
you
Please.
start, you start.
Well, I was going to transition us into, because I think Dr. Varden there really captured kind of the diabetes type 3 element of it. And I wonder, especially given cognitive health and brain function is such a focus of yours, if you could dig into some of the other genes that you mentioned, in particular BDNF, and how that plays into it all.
Yeah, so Dr. Bredesen and the Apollo Institute kind of break down Alzheimer's into 6 types. And the DNA company with all your reports have genes that relate to each of those types. So one of them is inflammatory, and your methylation genes are relevant and well studied to be a factor in Alzheimer's. So the MTHFR SNPs, we always hear about them. There's a specific SNP that we hear about. It's this C677T, I believe, and Krista, correct me if there was a number off there, but there's one main SNP that's always quoted, but really it's not just that one main SNP. There's a whole bunch of methylation genes. We have at least 6, or used to have 6. 7 now. And you want to look at overall some of the most well-studied methylation genes. How is your methylation, which is essentially on a practical level ends up equating to your ability to quench inflammation in the body. So it affects your intake and absorption of B vitamins. And inflammatory is one of the more common forms of dementia. So you want to look at your methylation genes. Those are relevant to that subtype, and they are contained within your reports. And you want to look at overall, is that a weaker section? And of course, some of the recommendations. So taking particular forms of B vitamins, and the devil's in the details with this one, because the methylated forms are not optimal for everyone. As me and Dr. Krista know, or Dr. Kosterman firsthand.
Yeah.
So yeah, check out your methylation genes. The first one, even before that, would be your ApoE, of course. You want to know what your risk is with that one. And then the second type is glycotoxic. So that relates to exactly what Dr. Varden was talking about in terms of glucose and its ability to affect cognitive function and reduce cognitive function over time. So that is it is a huge factor, even based on what I've seen in early cognitive decline and mild cognitive decline. People's cognitive function tends to get better even with just dietary changes if they're able, which sometimes requires a lot of support, but that is a big factor, and you can get more information on that through your report. And your insulin resistance and genes like TCF7L2 have been well studied and correlated with Alzheimer's. The combination of ApoE suboptimal and TCF7L2 is particularly important. So let's say you had a suboptimal version of both, you'd want to work more aggressively on prevention.
Okay.
And then
to confirm something you just said, though, so in your clinical practice, for people exhibiting mild cognitive decline, and we'll support the audience in a little bit with what that means exactly and how you can test for it. But for those people, especially I'm thinking to people who are here for information, or those who are caregivers and know someone, right?
Yeah.
A diet change will have meaningful impact, namely a diet change that reduces a diet that is already relatively high in sugars. Is that a true statement?
Yes, yeah, especially added sugars and refined carbohydrates coupled with lower protein. If someone is able to make dietary changes where they're kind of managing those factors, there typically will be changes in the course of months. The thing is, it's not instant, and it really takes sometimes doing a retest to see how it's affecting. So you can redo the MOCA. I believe the minimum period of time is 3 months. By 3 months, most people will forget
Yeah.
what was involved in the test, but that's one way to see whether it's working.
So a little bit of a tangent, because I know you were going to kind of jump into a different thought train. I wonder, Dr. Varden, if you want to speak briefly to what the MOCA is, because I think this lends to, those that are seeking to prevent. This is one way you can engage with your doctor to the ends of screening for and preventing, or at least getting on top of it should anything become worrisome in the results.
So the MOCA test, actually, it's MOCA. It stands for Montreal Cognitive Assessment. And there are several different kinds of tests. This is a more comprehensive test. It is administered by a medical professional, your doctor, and this includes tasks that evaluate executive functions, memory, language, visuospatial skills. So yeah, this is probably one of the more recognized and more commonly used tests, but there are others. And I do want to definitely stress that anytime that anyone is thinking, oh, they may have Alzheimer's or someone, allow the doctor to be the diagnoser. They are the ones who need to administer these tests, and any type of tests like the MOCA. Okay. I mean, there's other ones like the mini mental state evaluation and, other types, but these tests are often used in combination with a medical history, physical exams, other diagnostic tools like brain imaging, blood tests. All of these are taken into account together to diagnose Alzheimer's. Okay, so it doesn't work off of just, a questionnaire or a particular test. So, this is something you jump into on your own.
No, I like the humanization of it, right? So I'll offer a patient I have in my practice family history of Alzheimer's. And so there's a sincere concern, right? And they're working very proactively, but there's this kind of gnawing stress at the back of the head. And I'd say once a year they come in, they're like, I think I have it finally. Can you do the test? And so I'll run the test and it'll come back fine, like no change from the year prior. And then we'll have a conversation. We'll ask questions around like, why do you think this? And often it's like, I'm losing my memory. I'm forgetting things and this and that. And oftentimes that's more situational stresses that will cause that, right? And so I say this to the end of, yes, you have to be vigilant, but there's a beautiful care, I think, when you approach your provider with the concern and they have that medical history that they can compare against, as well as they can also find other reasons for kind of some of the memory slipping that are not the big A or the big D that we all start getting concerned about. So I really like, Dr. Laura, your idea of having tests and working with a provider to sincerely assess that, as opposed to fearing the worst, right? It's not often you get to a doctor and they're like, nope, you're actually good. Yeah. So jumping back into some of the genes and some of the more cognitive facing genes, Dr. Sapp, where did we cut you off? Where would you like to jump back into it?
No problem. Yeah, I just wanted to also highlight what Dr. Varden was saying, just in that it can be frightening, as we've talked about. A lot of people are really concerned about this particular illness. And just like as a first step, if you're 45 or older, getting your genes tested, particularly ApoE, would be a first step. And talking to your primary care provider about administering a MOCA, because it is a 10-minute, very well validated screener. So either they will just perform it in office or they can refer you out to another healthcare practitioner. It's not something you can self-administer. And it definitely has to be conducted in a particular way for accuracy, because there's a lot of potential there when it comes to memory for sort of subjective views that might not be accurate on one's own cognitive state. So yeah. But yeah, back to the genes. So another subtype of Alzheimer's was toxic. So the genes that would be relevant and that are well studied would be GST-M1 and GST-P1 as two of the main detox genes that have been associated with Alzheimer's. So basically, when we've looked at those, remote studies we referenced about parts of the world without any cases, despite genetics, they typically were rural areas where people didn't have as many environmental exposures. So it's a combination of us all living in a modern environment with lots of toxic exposures. And then when you have those suboptimal genes, you essentially have to work extra hard on processing the toxins in your environment. And those can be glyphosates, benzenes, medications, alcohol, air pollution. It all kind of adds up. Some of the things you can do to improve detox, one of them is infrared sauna, and that's been shown to help cognitive health. It's even a very minor factor in Alzheimer's prevention. And then there's, of course, detox supplements that you can find out more about through a DNA co-report, but there's milk thistle, there's NAC, there's different ones that help mitochondrial health as well. But basically lowering your toxic burden. The Environmental Working Group is a great resource for that. They have the whole Dirty Dozen, which is the most pesticided crops of the year, and Clean 15, the least pesticided crops. So you can make things more economical for yourself. But basically detox and the genes GST-M1 and GST-P1 are studied and relevant in that particular factor of Alzheimer's. So yeah.
So for people with their 360 who are frantically figuring that out, that's in the inflammation section. And then this is the GST-P1 as in Peter 1, and then GST-M1 as in Michael 1.
And mold, actually, I'm just throwing that in there because that is something that we're seeing more and more of. In terms of why that is, there's a lot of theories out there. I suspect climate change. That's one of the proposed theories out there, but mold toxicity is becoming more and more of an issue. So for people who may have had exposure to mold for long periods of time, who may have colonization, taking care of that would be a factor, particularly if you have suboptimal detox genes. So yeah.
Dr. Varden's done some brilliant material with people from the Got Mold company. So I wonder if the powers that be can also post that, because Dr. Varden, you've become a bit of a resident expert when it comes to mold detection, mold awareness. I don't know, powers that be, if you could post in the chat some cross references there in case people want to dive deep into mold.
Actually, we're going to be doing a podcast. I'll be doing that with them. I think it's next week. So we're going to have another episode with Jason Earl from Got Mold.
Wonderful.
We already have some wonderful material, some wonderful interviews with him, but we are going to get to have him back on. So, asking some more probing questions about mold.
Awesome. I'll have to check that out.
It works into and makes you realize what I said before, that it's not just one thing. Like Dr. Sapp and Dr. Kosterman have said, there is so much more going on that the genetics in themselves, that's not the fatalistic thing. What you really need to look at is your life, the food you're putting in your mouth, the toxins you are being exposed to, the sleep that you are getting. Sleep. Yes.
Our favorite topic here.
Yes. One of my favorite topics outside of poop. You need to be eliminating, the toxins that your body is trying to clear. But sleep is amazingly important. It truly is one of the absolute foundations for good health. And actually, Dr. Matthew Walker, in his book, Why We Sleep, talks about this and talks about Alzheimer's and the studies that have been done, that when we sleep, especially during deep sleep, this is when our glymphatic system, different than our lymphatic system. Lymphatics is like neck down. Glymphatics is in the brain. And this is where the glial cells will actually shrink up to 60% of their size and allow almost like a dishwashing effect in the brain to clear, these protein plaques and other particulates and toxins, and be able to just wash them right away. This happens during deep sleep. And this is what they have tested. They have tested that in the cerebrospinal fluid, at how well, how long, how much deep sleep someone is getting, and how many of these proteins and other toxins are being flushed away. This is one of the reasons why it's so important that you are sleeping. Again, three main things that I ask my clients. Are you sleeping? Are you pooping? And is your blood sugar regulated? Those three things foundationally affect your predisposition or risk possibly getting Alzheimer's or dementia.
Yeah, I think
that's a really good summary, Dr. Martin. And if I could just continue on that, other than some of the concrete steps on looking at your risk, let's say once you're 45, that is the recommendation from the Apollo Institute, which is a cutting edge institute in Alzheimer's prevention and treatment. But other than that, let's say you just want to start today with a couple of things that will reduce your risk. An anti-inflammatory, low glycemic diet, so less added sugars, less refined grains, more proteins and vegetables, essentially. That is a top factor. Getting enough sleep as much as you can without stressing yourself out about sleeping more is a big factor.
You can tell she's worked in a high power executive clinic when she's like, get more sleep, but don't stress yourself.
Very true. Saw a lot of that. But over the years, like even starting in my internship, as an approximation, I'd say maybe 8 in 10 people I've seen have some degree of sleep issues. And most of those people think it's just them, which I find, upsetting, troubling, just in the fact that most people can improve their sleep over time, and just knowing that insomnia is not a static thing per se. We can all improve our sleep over time. And then another is exercise. I mean, most people know it's kind of a magic bullet. We don't want to overexert ourselves either. And that all depends on your particular constitution. But cardiovascular exercise, stress reducing exercises, walking, that's all part of an Alzheimer's prevention protocol. Sleep, diet, and then of course stress is huge, right? We want to have a little bit of stress, like a little bit of cortisol. We want to have a cortisol response, but we don't want to have too much stress. So it's like it's a happy medium, but most people are kind of in the point of diminishing returns once they hit a certain age in our culture. So keeping that in mind, we want to work on stress.
Yeah, which the tricky of that too, I find people who aren't stressing have more stress, and people who have more stress aren't sleeping, and it's this happy chicken and egg that feeds one another.
Yeah. Although we are getting more and more kind of resources out there, like books like Matthew Walker, like a lot of this stuff is fortunately making it out into the mainstream. And so, using a growth mindset, like I think it's good to acknowledge that they can all be worked on without overstressing ourselves about it. So
yeah, and even following these leaders in the field like Dr. Dale Bredesen, and his last name is Bredesen. So if
Yeah.
you want to look him up, that he's got some great information. He's done interviews and other trying to think. I think he did a TEDx.
Yeah, he
Oh,
did.
okay.
Yeah.
Yeah,
That sounds right.
yeah.
Mhm.
So I mean, just look up his name. Fantastic information. Another leader in the field of brain health, Dr. Daniel Amen.
Yes.
Mhm.
Yeah.
Fabulous researchers and doctors, always having some great information. And, there's also Jim Quick, who does a lot with, brain health and keeping your brain strong and active. And that's very important as well. We don't want to become complacent. We need to work those brain cells. What fires together, wires together. And this helps to increase BDNF, that brain-derived neurotrophic factor, which is also one of the genes that we look at that you'll find in your mood and behavior report, because this really works in that neuroplasticity and the growth of the neurons, for brain health. So definitely something to be looking into.
Yeah, I wonder, as we start to kind of ask ourselves the questions of prevention and what are on people's minds, I wonder if we can start to transition to our Q&A section, because given the wealth of knowledge that sits between you two, there's been a lot of questions that are trickling in. And so I'm going to start pulling a few of them. So I'll allow, I think, I'm not sure who would want first dibs on this one, but Cindy's asking, do multiple white plaques on brain imaging, so brain imaging, because we don't really see that until postmortem, but on brain imaging, does that indicate Alzheimer's or MS? So I'm imagining very distinct diagnoses, but from an imaging perspective, both one of their hallmarks are going to be white plaque formation within the brain, or at least more specific, I think, to MS. Maybe Dr. Adelia, if you want to speak to some of the imaging results there.
Yeah, so the thing is, I actually don't look at imaging associated with Alzheimer's. It's often a neurologist or a neuropsychologist or a specialist that a different kind of specialist essentially, although I do order imaging. So in Alzheimer's, plaques can be beta amyloid plaques. Those ones are typically not white based on what I know. So based on what I know, it is more associated with MS. But like I said, I don't typically read the Alzheimer's associated MRIs. I'm not usually the one reviewing them. I'm usually the one working on a preventive or early stage treatment plan or administering a MOCA, because I'm a primary care doctor in Washington. So. Yeah.
Well, if I can interject and give a little bit of clarity on this, that you're correct about the beta amyloids, that generally they don't show up as white plaques, and actually they're generally not visible on a standard MRI. They usually have to be identified through specialized PET scans or confirmed, obviously through a brain biopsy, but that would be after death. So white plaques often seen on an MRI, not typically associated with Alzheimer's. This is like Dr. Sapp had said, usually you'll see that with MS. But again, this is not a diagnostic thing that would have to be done through your doctor, through, the radiologist, or, whoever is reading these scans. And then, also looking at your history, all of these other aspects. So we don't work off of just, these images.
Often by time those images are ordered for a person, because there's concern of either condition, especially for MS, it's a radiologist or someone who's trained in the space that would be interpreting and then passing that client to a care provider who's focused and specialized in that space. Yeah, so the next question I have here from Barbara, she's asking about the blood-brain barrier, namely things that can cause damage to it. And so one of her questions was, can COVID cause that damage to the blood-brain barrier. And so I'll offer it out to either of you ladies. Are you either familiar with, I know there is evidence that COVID, in particular long haul, or kind of that lingering post-viral presentation of COVID, demonstrates damage to the blood-brain barrier. Do either of you care to elaborate beyond that? I think this really goes back to the idea that within Alzheimer's, this blood-brain barrier can be compromised. So we want to be very clear here. This is not saying COVID will cause. This is a comment on the impact to blood-brain barrier. And we know that ultimately a diminished blood-brain barrier is part of Alzheimer's. We're not saying one causes the other. We're just simply talking about blood-brain barrier and what can kind of be aggressive against it.
So I'm going to jump in here for a second, because I will say that there is ongoing research, constantly about COVID-19. This is all still very new, even, the last 4 years or so. But when we are looking at whether COVID-19 vaccines or the virus itself affecting the blood-brain barrier, some of the research, what it has been found is that, well, first of all, that COVID-19 can cause inflammation throughout the body, including the brain. That inflammation can lead to breakdown or dysfunction in the blood-brain barrier in some cases. The virus can indirectly affect the blood-brain barrier through the release of these inflammatory molecules called cytokines. So, that's where the viral aspect. Now, with, excuse me, with the COVID vaccine, now there is not a lot of evidence or research on this, but with the fact that with the, spike protein and with these microclotting that can happen in the cells because of the spikes, that can actually cause some ischemia, basically where, certain areas, certain tissues are not getting blood flow, oxygen, nutrients that it needs because of this microclotting. So therefore, that can also cause some issues, not to mention that, again, these are very, very small and they can cross the blood-brain barrier, especially within the nanoparticles, because those can cross. So again, there is a possibility, we just don't have strong evidence, direct going through.
Yeah, so we have growing evidence in regards to, in particular, COVID-19, the virus itself impacting blood-brain barrier, be it through indirect inflammation or a little bit more direct to the blood-brain barrier. And so it's something, I think, should you have COVID, or in particular long haul, right, the post-viral condition after the fact, right, really seeking support, because while there's no evidence that says that will then lend to, it's something clearly that you want to be tending, because having a tended blood-brain barrier is something you want to the end of prevention. Yeah.
And I think clinically, like some signs that you may have, and again, you'd want to confirm this with your clinician and testing. There are some actual tests out right now that specifically measure the blood-brain barrier. There's one by Cyrex, which I've used before. But anyways, if you had COVID and then you have symptoms like brain fog afterwards, that is like one indicator, like one of the kind of main indicators, that or prominent fatigue or anxiety. Those can be indicators that you have some degree of neural inflammation. So inflammation of the brain or nerves related to COVID. And then you would want to work ideally with a functional medicine practitioner on that. So.
Thanks for that, Adelia. And sorry, Dr. Sapp and Dr. Varden. Yeah. All right. I want to move on to Stephanie has a question for us. And so I wonder, so Stephanie's saying she has the 3/4 gene, right? ApoE34. And then as well a family history of Alzheimer's within the family. And so she's saying that her detox genes aren't great. And so she kind of very much presents as the healthiest sick person insofar as it sounds like there's a lot of preventative efforts on her part. Now, I guess her question, this is a very, at least I hear this in my practice often, it's a very common question, right? Should she work on everything at once? So she has her 360, she knows her detox isn't great, and there's a few other health things that she has going on. You know, what would your counsel be with awareness? You don't know the specifics of her case. Does she tackle everything kind of at once? Or if she came into your practice, would you want to focus on an individual element of her health, be it detox, be it sleep, be it whatever, before moving on to something else? You know, she's looking to the end of prevention. She wants to be the healthiest healthy person. She knows. Does your clinical practice have you boiling the ocean, or do you take a cup and try to move forward with people in a little bit more of a step manner?
As a first step, and depending on if she has any symptoms whatsoever, if she has any subjective symptoms like, oh, my memory's really gone down, I'm finding myself, disoriented or less organized or things like that, then the best thing would be to go to your primary care provider and ask them about a MOCA screener, which only takes 10 minutes. It's not the end of the world if you have like a suboptimal score. If you have a score of 18 to 25 out of 30, that would be mild cognitive impairment where you would want to work on everything. Basically, you would want to do a more comprehensive protocol. If you have a score over 25 on 30, you're probably good, and you want to just work on the foundations of health. So other than pursuing some sort of screening, the foundations of health, like Dr. Varden was talking about, like stress, sleep, diet, stress management, would be the areas to work preventively, as well as the recommendations that target those specific genes in your report. So,
And I'd really start with the low-hanging fruit first.
yeah.
What is the easiest thing for you to change first? It's one step at a time. When you are walking 1,000 miles, it starts with the first step. So, if that is stop purchasing packaged foods and getting a bit more whole foods, actual vegetables that, don't have a little tag, or a little nutritional label, start shifting over one thing at a time.
Yeah. That's good advice. Yeah.
Yeah, I like that. I like both of those. The idea that, it's a little thing that you can do every day, coupled with here's a very tangible measure your doctor can give you as to, yeah, my cat's here. I love the new celebrities here. I like that people in the chat know her now. As well as Dr. Sapp's advice of let's get some grounding as to how concerned we need to be, because that can, again, focus energy and effort, right? Yeah, so our next question comes from Carol. And so I think Carol's jumping a little bit back to this confusion around what is dementia, what is Alzheimer's, how do they relate? And so she's saying Alzheimer's is under the umbrella of dementia. So close. Alzheimer's is under the umbrella of dementia. When you're told you have dementia, does this mean you have Alzheimer's? And if not, what exactly does it mean to be told you have dementia?
Yeah, so dementia is the umbrella term. Underneath that, one of the types, or the more common type, would be Alzheimer's. But if any kind of healthcare practitioner used the word dementia, they could also simply be referring to mild cognitive impairment, which implies that your cognitive function isn't optimal, but you're somewhere along the continuum, and that you might want to work on it. But basically, underneath dementia, there's Alzheimer's disease, vascular dementia, Lewy body dementia, and frontotemporal dementia. So hopefully that clarifies a little bit.
I like those fancy words. I do want to kind of call back to Stephanie. So this is Adelia, the advice that you offered a little bit before. She's just offering a little bit of clarifying information. So she's postmenopausal. And so that I don't know if that impacts kind of your assessment or direction, but postmenopausal, and there are elements of brain fog. And so, is that, the question especially of, is that postmenopausally related? I would imagine how would that change kind of your advice there?
Yeah, in the sense that, so I would still say that just doing a MOCA, an initial screener, would be a good idea. But if you suspect there's any kind of hormonal involvement, that is actually a factor in Alzheimer's progression. So getting your hormones tested, and talking to your doctor about this, obviously, whether pursuing bioidentical or hormone replacement therapy is a good idea in your particular case with your family history. Not having a sudden dip in hormones in menopause can be helpful as part of a preventive protocol. So talking to your doctor about a MOCA as well as hormone screening would be part of it. So yeah.
All right. So our next question here is from Diane, and so I'll offer this one to Dr. Varden. She's asking if we could specify which ApoE genes qualify as suboptimal, and are there any that are considered optimal, or she's using the word protective. I wouldn't go so far, but kind of can be advantageous in regards to ApoE presentation.
Absolutely. So remember that the ApoE gene is involved in making a protein that helps carry cholesterol and other types of fat in the bloodstream. So remember, it's an ApoE stands for apolipoprotein. The lipo part means fat. Okay, so fat carrying protein. Problems in this process are thought to contribute to the development of Alzheimer's. So ApoE comes in several forms called alleles, ApoE2, E3, E4. So it's the ApoE2 that I think where she was thinking more of the protective aspect, because, they do actually on the NIH website, they actually state that the ApoE2 may provide some protection against the disease. But if Alzheimer's does occur in a person with this allele, it's usually developed later on in life than it would in someone with, say, like the ApoE4. And for people, there's only about like 5 to 10% of people with the ApoE2 allele. What's more prevalent is the ApoE3. This is the most common allele. It is believed to have a neutral effect on the disease, neither decreasing nor increasing the risk of Alzheimer's. But when we get into the ApoE4, that they have, research has shown that it does increase the risk for Alzheimer's and associated with earlier onset in certain populations. So we're talking about, 15 to 25% of people have this allele, but only, like what Dr. Sapp was saying, very few people, only like 2 to 5% of the population actually carries 2 copies of the ApoE4. So, that's the breakdown between those 3 types of alleles.
And just to round this question out a little bit, Lisa is asking the question, do we have any insight on ApoE, a 2-4 combination? So usually you'll hear about this in the combination of 3-3 or 3-4 or 4-4. So 2-4, additional to 2 being such a rare allele, this combination is exceptionally rare. And so there's not really ability to study large populations of it. It's a lot based on casework. Casework meaning we know one person who has it, let's study their outcomes compared to others. And so based on this very extrapolated, meaning we don't have a lot to go on, but what we are able to gather and collect is that people with a combination of 2 and 4 tend to present and tend to have similar outcomes as people who are 3-3. So what does that mean? 3-3, Dr. Varden just kind of said, it's a bit of a neutral. It's not beneficial. It's not detrimental. It's kind of you're happily in the middle. It's really your diet and lifestyle that will predict risk. And we are finding that people with 2-4 tend to sit in that camp, in the sense that the very protective beneficial 2 is, or I won't say protective, the beneficial 2 tends to be very balancing and protective against some of the detriment that can come with carrying that 4. So if you're one of those very rare unicorns out there with a 2-4, you're probably similar to a 3-3. But again, that's a little bit speculation on science part and a very educated guess. All right. So the next question we have here, actually, it's one more of a clarifying question. So Dr. Lara, when you were speaking to glucose and insulin and all those other fun things, you mentioned an S gene. Do you want to go through the SLC again for the audience?
Okay, so that's the one that we were talking about, or that I was talking about, for zinc transport. It's a solute carrier gene. That's what the SLC stands for. So it's SLC 30, the number 30, the letter A as an apple, and the number 8. So it's SLC 30A8. And that's the zinc transport gene that is associated with insulin production and transport.
Yeah. So if you're looking for that, you'll find that in your diet and nutrition, specifically the micronutrient section.
Yes.
Yeah. All right. So let's see here. We're also, I guess there's a question here in regards to alcohol and dementia, namely, do alcoholics have an increased risk or an inevitability towards dementia? Dr. Sapp, what are your thoughts there in the relationship?
Yeah, Dr. Varden, I don't know if you've looked at any research on this. It's definitely a factor in that it can affect your detox capacity. So basically it fills, if you think of your toxic burden, overall toxic burden as a bucket, having more alcohol in that bucket will fill it and give you less capacity to detox effectively overall. So detox and toxic burden is definitely a big 1 out of the 6 main factors in Alzheimer's, although I don't know specifically of any studies indicating that alcoholics specifically are more likely to get Alzheimer's. I would suspect yes, that would be an educated guess, but I don't know of any studies.
Yeah, I don't know of any particular studies off the top of my head, but anything that starts to increase your toxic load is going to be, problematic, and you certainly want to decrease, mitigate any toxic exposures, alcohol included.
Okay. So the next question I have here, or at least I'm gonna pull together a few because they're all along the same vein. So a lot of people are really curious in regards to sleep and sleep quality, because we very much said the 2, risk of dementia is inextricably linked with some quality of sleep. And so some of the different questions we're getting is, how do we improve deep sleep? And separate to that, especially if you're someone who struggles getting sleep, if you go to sleep with a sleep aid, be that a supplement or, something a little more aggressive like a medication, is it still the same quality of sleep? Are you still getting the same benefit there? So I wonder, maybe if we can speak to both as to the importance of quality sleep and ways that you can optimize it that actually optimize sleep, as opposed to, I know some people who take, something just to knock them out, they don't necessarily get a quality sleep, right?
Yeah, I think a lot of people have, fear around sleep aids. And I know there is some research suggesting that some categories of sleep aids are associated with Alzheimer's. But I think it's also really important to factor in the cognitive decline that can come from sleep deprivation itself. So it's a question of weighing those. And even if the quality of certain stages of sleep may be affected. If you're sleeping more hours overall at night, that's generally going to put you into a better position. So it really is something to talk to your doctor about. But taking sleep aids and there's no shame in taking sleep aids of one kind or another if you're responding well to them and they are increasing your overall hours of sleep. So which sleep aids those are, whether they're natural or less natural, that's a conversation to have with your healthcare practitioner. But just increasing your sleep and being able to sleep is pretty important to consider in that whole cost benefit analysis.
And we do have to be careful about the one pill fix,
Mhm.
because any type of sleep aid is, yes, it could be helping you get to sleep. But then there's the whole nuance thing. Is it quality sleep? A lot of research says not so much. But then again, what is it? But you need to focus on, first of all, if you do need a little help, fine, but get to the root cause of why are you having sleep problems in the first place? Okay. A baby sleeping, little kids sleeping, they don't need sleep aids to sleep. We didn't start off, needing sleep aids to sleep. So understand and try to figure out, while you may be needing a sleep aid at first for a short period of time, think it as a therapeutic situation, but then get to the root cause. Because ultimately, when you're talking about good sleep, remember the QQRT: quantity, quality, regularity, and timing. You focus on each of those 4 pillars, you can start, working your way on, clearing up, figuring out, okay, what do I need to do to get better sleep? So specifically answering some of the question about how do I improve my deep sleep? Maintain a consistent sleep schedule. Okay, go to bed, wake up, same time every day, even on the weekends, even on vacations, as best to your ability. All right, that helps to regulate your body's internal clock. It helps to improve the quality of your sleep. You want to have also relaxing bedtime routine. This gets into your sleep hygiene, okay, which is something we work on in our programs. You want to optimize your sleep environment. Take a look around your bedroom. Do you have lights on? Do you have blackout shades, or is the whole room lighting up every time a car passes by? What's the temperature of your room? What kind of mattress are you sleeping on? What kind of bedding? What are you washing your bedding with? Is it these very fragrant laundry detergent and other things? These are exposing you to more toxins when this is the time that you're supposed to be clearing them. So, these are just a few things, outside of, obviously what Dr. Sapp was talking about, regular exercise. Okay, this helps sleep as well. Avoiding caffeine or alcohol close to bedtime or larger late meals can actually negatively impact your sleep. All of these things. And we had a wonderful webinar talking about sleep that you can always go back and visit.
I was just gonna say, because I love that you're summarizing points that I think deserve elaboration on, and I wonder if the powers that be can share some of the webinars we've done in the past on sleep. Yeah, thank you, Dr. Varden. Thank you, Dr. Sapp.
I just want add, Dr.
No?
Varden, that's a really good point in terms of working on the factors. So just in terms of people who are extremely sleep deprived, sometimes they need that sort of short-term Band-Aid. But definitely a lot of those sleep medicines, if it is like one of the less natural ones, quote unquote, do not work long-term, a lot of them. So you kind of have to work on both levels. A lot of people, sleep hygiene really works over time. You just might not notice it working right away. But getting to the root cause is super important. So working in the short term and the long term can be both important, essentially.
Sleep trackers.
Sleep trackers are
Take
great.
the
I thought
data. Yes.
Yeah.
We love the data.
And
you
the
can
other
track and
thing
follow.
is, yeah, absolutely. If I could add one thing, sleep apnea is super common. So if you have any concerns, get screened, because it's not just a CPAP machine. There's a lot of options out there.
Yeah. Yeah.
Yeah.
No, that's a good call out, right? I think, if you have sleep apnea, and just simply fixing that can probably be your number one dementia reduction technique.
Yeah.
All right, I'm gonna continue on in some of our questions that we have. So Lisa is asking, she's read that there's an HLA gene that is significant to ability to detox mold. Is the HLA gene tested for within the DNA 360? So I'll be specific as to how we test for it. So HLA is a gene that's been very much examined in regards to immunity and more focusedly autoimmune conditions. So people with certain SNPs will incur certain autoimmune conditions based on certain SNPs within this gene. So again, we're not a company that per se peers into disease-defining genes, but HLA is very important to us insofar as we examine 6 SNPs within it, or if we're thinking of a gene as a book, we're looking at 6 pages in the book. And these pages in the book are very important towards either celiac or gluten sensitivity, right? So celiac being the more clinical pathologic presentation, gluten sensitivity being a little bit more within the gut and how you respond to the protein, okay? And so how does this play in with mold, at least from our perspective, right? So we think of, I think a lot of people when they talk about gluten, they think about the protein and they kind of assume it means the wheat as well, right? But we have to remember that gluten, the protein, is part of wheat. And unfortunately, based on a lot of the agricultural practices within North America, and now as well Europe and Asia and Africa and South America, and I almost think globally, save and except for a few countries, wheat is not just wheat anymore. It's a manufactured product and it accompanies a lot of glycophosphates and a lot of other natural meaning mold, or unnatural meaning synthetic pesticides, herbicides, etc. So when you take this in, by and large, it tends to be a very laden product. So how it kind of can come back to the mold is we look at GSTP1 as well. So GSTP1 really curates how do you manage mold, right? And how do you manage a lot of the glycophosphates, a lot of the things that will accompany wheat, okay? So you can look at your HLA that really speaks to the gluten sensitivity. And for those that are out there and like, I have a perfect HLA, but I still can't take wheat, probably very indicative of, issues within GSTP1 or just your GST family. And to both Dr. Sapp's point, to Dr. Varden's point, we kind of look at several factors. So if you're someone with poor HLA plus poor GSTP1, kind of the overtime duty of being extra vigilant there, because not only is that going to create inflammation within the gut and within body, it will impact your brain, especially those that are sensitive to gluten. There's a lot of research that looks at how that impacts blood-brain barrier, how that can cross the blood-brain barrier. It's kind of this just like, it's like taking sandpaper inside the body and messing everything up. That is, for some people with genetic susceptibilities, that is what gluten, wheat, and the herbicides, pesticides, molds, so that happy little trifecta family can create within people. Yeah, I hope that was a comprehensive rundown. The next question I have here is from Sonia, and I'm going to actually toss it out to the powers that be, the gods that be. I wonder if Dr. Varden, Dr. Sapp a few times have mentioned thinkers within the space of Alzheimer's and dementia, if you could just put those names into the chat so that people can jump into Instagram and Google and all those other spaces. Okay. The next question I have here, and I'm actually not sure if our panel can answer this one. So Janice, we may not have a thought on this, but does anyone have thoughts on Vielight, Vielight? It's a Canadian company. They're doing their own research on the effects of light in regards to Alzheimer's, Parkinson's. So I'd open that question up. Do either of you have awareness around the impact of light? You know, I'll allow you to define how you want to define light. But any insight into the correlation, the impact of light on Alzheimer's, and this can include circadian rhythm and sleep too. I want to make sure we keep this as open and broad as possible.
Yeah, I don't know how accurate I can be in the specifics of that one. I know that Vielight was a company that people were discussing at the Apollo Institute. So I do believe that there's some research showing that it can be helpful in preventing cognitive decline and in treating early cognitive decline, but I can't speak to any of the specifics, nor do I think it's technically part of a Bredesen protocol yet, but don't quote me on that. It's definitely an area of upcoming research that's being looked at more and more. Yeah, another thing is infrared light. There's some evidence that it helps cognitive function. So, yeah.
Well, a lot
So
of that, I will say the research with the red light therapy, infrared, is that it helps for mitochondrial function. When you're talking about mitochondrial function and you're talking about energy, that's what you need for the brain. Because in Alzheimer's, you end up having an atrophy of the brain, of the cells that make up the brain. So anytime that you have your mitochondria, cellular functioning working well, other things are going to work well. And actually diving into light exposure a little bit more, I mean, seeing that this light exposure does play a very significant role in regulating the body's internal clock, that circadian rhythm, which affects sleep-wake cycles, affects mood overall. In people with Alzheimer's, proper light exposure, this can play, an important role in many different ways. First of all, it can help regulate the circadian rhythm. They have found that in Alzheimer's patients, circadian rhythms are often disrupted. That leads to problems like sundowning. Basically, that's the increased confusion and agitation in late afternoon or evening of these patients. Difficulty falling asleep, frequent nighttime awakenings because that circadian rhythm is being thrown off. So for proper light exposure with bright lights and that re-regulation can definitely help. Also, I had mentioned about mood, improving mood, and it can help reduce agitation for these people because sunlight, natural sunlight, can help boost the production of serotonin, that neurotransmitter that's associated with happiness and well-being. So, when they have this allows them, to upregulate that neurotransmitter and help lower any type of depression, anxiety, agitation. So I think that's a few little highlights on light exposure.
Absolutely. It also increases vitamin D, particularly if you're in areas like the Pacific Northwest, where a lot of people are deficient. I'm already demonstrating signs of living here. But yeah, vitamin D and circadian rhythm. So it's indirectly, there's a lot of links suggesting it's important. So yeah.
Thank you, ladies. I like the various areas you touched on there. We have Kathy who's asking, do we have feelings or opinions? Actually, let's sit with opinions as opposed to feelings. Do we have opinions about using molecular hydrogen for dementia and or Alzheimer's? I have feelings, definitely, but do we have any opinions?
I don't have a scientifically based opinion. So I'd like to hear your thoughts, Krista.
Yeah,
I
I
don't
think
have any.
yeah, yeah, I know that hydrogen water in particular coming out of Japan, there's a lot of small studies that look at some benefits. I would offer a lot of that has not been studied clinically speaking in populations with dementia or Alzheimer's. And so while I think oftentimes marketers and researchers will try and twist very small end studies to say, hey, it cures all and here's what all is, be very mindful. And I think if you're looking at where do you invest your energy and effort, be it in prevention or you have someone who has this, it would not be my go-to because I do not think there's clinical evidence yet suggesting that is a meaningful impact, especially proportional to the cost. Yeah, but
I would second that in the sense that it's not one of the main studied factors in a treatment protocol or preventive protocol.
And everything starts somewhere, right? I don't want to sit here and be like, it's not. I think it's the statement of we have to be very mindful of our resources and also very mindful that sometimes advertising companies will twist words to encourage purchases. So something just to be mindful of there.
You know, I do want to say though, not that obviously there's not a lot of research specifically in that, but the biochemical reaction of molecular hydrogen being a selective antioxidant, okay, meaning that it targets and neutralizes very harmful free radicals, okay, that can affect, the mitochondria, the cells. Okay, so anytime that you can help to remove these molecules, these free radicals, then you're helping the cell, you're helping the mitochondria, you are helping the tissues. So even though there is not direct evidence of, oh, molecular hydrogen, and how does this work on Alzheimer's? The fact that it's good for as an antioxidant. So it's a general thing. It's probably not the first thing I would jump to. Again, it would be looking at what is your lifestyle, what is currently going on that you can start making easier changes. Again, the low-hanging fruit. Start with easier things, build on. Now, if you have done like all the stuff, you've cleaned up your diet, you are really, a major biohacker and you've already done all of that stuff and you're looking for what's that extra little thing that I can do. Sure. Yeah. Do the molecular hydrogen. There's a lot of other benefits, just in general that it'll help. So it's not like it's not going to be beneficial in some way.
It falls under that really interesting space of like bleeding edge science in that, there's nothing identified currently as harmful and the studies as to whether it's worth it and what conditions are still coming. So if you're a biohacker that's looking to play with yourself and really be precise in your N of 1, it could be something interesting, but at present, nothing that we can recommend specific to Alzheimer's or dementia. All right. Aisha, I'm hoping I'm saying that right. She's asking, what is the name of the gene that's associated with Alzheimer's in the 360? So that's APOE, so APOE, and that can be found within the cardiovascular section, interestingly enough, because as Dr. Varden mentioned previously, that also has a lot of influence around lipid metabolism within the body. Yeah, all right. Okay, so Catherine is asking the question. So she has the APOE gene for Alzheimer's, so I would imagine she has a 4 variant, and she wants to avoid triggers. What do you know about having repeated cold sores? So cold sores coming from the HSV virus. She read that HSV can be implicated in Alzheimer's. And so she was wondering if we have any awareness around that. And, is our cold sores per se something that we should be concerned with aggravating Alzheimer's or being directly related to?
So I have some thoughts, just in that HSV2 is very common in the population. It's not one of the top things that I would be concerned about. Any kind of viral load could contribute to your overall toxic load. But Krista, I don't know if you, Dr. Kosterman, I don't know if you know any statistics on how common it is, but I believe it's almost 1 in 2 people that have HSV2.
Yeah,
So it's
I,
quite common, essentially.
yeah,
And it's not necessarily one of the main factors that I would be concerned about in an Alzheimer's prevention protocol. So
yeah, I think approximately 80% of the North American, I don't have statistics outside of North America, but 80% of the North American population has the virus dormant within. That is not to say 80% presents with it. So what will happen is you contract it once and then it goes and it hides in your spinal cord. And when the terrain, the environment is correct, that can be inspired to come out, and that will come out and present as a cold sore. Often people will see it on lips, mouth, sometimes within genitalia. And so often things that will inspire it out are stresses. So what can a stress be? Anything, within your workday, not getting enough sleep, you've been sick. So those different sorts of stresses will kind of shift the immune system to the point where the immune system is no longer able to suppress the activity. And so then the virus comes out. So I cannot comment on the direct link, but I would offer, if you're frequently getting these presentations, there's an element of your immune system and its inability to manage that, which for most of the population, given normal circumstances, can be managed. So I would offer that's an indicator to me, at least, to work with a clinician and to understand what is so consistently aggravating the immune system. There's several different supplements that can be to the end of supporting it, right? I know lysine, creatine's a very interesting one. Both can go to the end of preventing incidents, but I'm still, to quote Dr. Lara, you really want to dig down to the root cause there and understand what's imbalancing the immune system. Because while I can't speak to the direct correlation between the two, frequent presentation suggests something's amiss with your immune, which will then lend to inflammation and other factors that will lend to Alzheimer's, dementia, cancer, kind of all those things that we concern ourselves with not wanting to have and to prevent. Okay, we're in the home stretch here, ladies, and to the audience, and thank you to the audience who's sticking with us here. This next question is from Carol, and it's for Dr. Atilia, or Dr. Sapp, if you just want to kind of offer again your definition, or at least your explanation around frontal lobe dementia. And, in a nutshell, I think this would be a more just, can you repair this? Or at least is there an ability to reverse this?
So I've actually worked mostly with mild cognitive impairment and Alzheimer's, as well as subjective cognitive impairment. So frontal lobe dementia, I believe, can be worked on, but it's definitely hasn't been an emphasis of my training. So I don't want to misspeak on that one if you have been diagnosed. Most of the types of dementia, other than early onset Alzheimer's, we can see improvements through functional medicine. I just don't know about the degree in frontotemporal dementia specifically. You can reach out to me on another medium if we are sharing contacts. I can into that.
Yeah, if you want to just toss your contact information privately into the chat. I'm not talking to Adelia, I'm talking to, I apologize, I just dismissed the question, so I believe it was from Carol. If you want to toss in some contact information, Brandon, I believe, can get in touch and support possibly engaging with Dr. Sapp through our clinic.
Okay. She had specifically asked what frontal lobe dementia was and if it was reversible. So I mean, I can actually jump in and just kind of give like an academic type of information here. So frontal lobe dementia, it's also known as frontotemporal dementia, or FTD, which actually works into our last question by Rhonda. And this is a type of dementia that primarily affects the frontal and temporal lobes. So here and here of the brain. These are responsible for controlling behavior, personality, emotions, language. And unlike Alzheimer's disease, which mainly affects memory, FTD, frontotemporal dementia, often leads to changes in behavior and personality, difficulties with language, problems with decision making and planning. I mean, there are different types of FTD. It's not just a single disease, but rather a group of related disorders caused by progressive degeneration of the frontal and temporal lobes of the brain. So I hope that answers enough of it. I'm not going to spend the time to dive into the three main kinds, but you know, really when it comes to how do we heal the brain, you know, because that's really what it comes down to. All the things that we've been talking about, you know, it's like clean up the terrain, you know, diet,
like
nutrition, stress, sleep, you know, all of these things. Your body is always in a state of healing and repair. We just have to get out of its way. We have to give it the tools it needs, the nutrients, these basic building blocks to rebuild and repair. And we have to lower that toxic load, get the wrenches out that are gumming up the system, you know, that are slowing that repair process.
Yeah.
And these are all the things that we've been talking about.
I love that. I love that. Such a beautiful way to kind of capture the evening insofar as, you know, we may not per se be able to halt or at least reverse progression, but we can, there's a lot of lifestyle diet interventions as well as more specific measures, especially through Bredesen and a few others that can go very well and long to the ends of prevention or disease mitigation once it's in place. And so I wonder, I think that's a point with which we can start to conclude our evening and offer, or at least I'm going to start with my incredible gratitude and praise of you both. Thank you so very much for joining us this evening and offering both your experience and your expertise and the care and compassion behind this, because I know our audience is kind of, some are here for prevention and some are here witnessing this in another, and the fear of, you know, what about me, or how do I stop it? So thank you for so masterfully offering to our time tonight. We're so very grateful to you both. And thank you to the audience who's been here and offered the questions and the care and the concern, especially for the caregivers out there who are supporting someone and watching someone go through this. We're very grateful for you, and we hope we've offered some things to the end of things you can do to prevent, as well as better some of the outcomes in the people that you're working with. Yeah, so ladies, thank you very, very, very much. I'm so grateful for the time, thought, and energy you've offered us this evening. And I think that's where we wish our audience adieu and au revoir and all the other niceties. Thank you guys. We'll be back again tomorrow night and we'll see you then.
Thank you so much.
Day.